speakers come up. So we have such a, I'll moderate the discussion at the moment. So we are at the nominal, my name's Peter Nigrovich. I'm at Boston Children's Hospital and the Brigham and Women's Hospital in Boston, an adult and pediatric rheumatologist. I'll moderate this discussion. I know we are at the break time, but Rashmi has graciously given us a little extra time now because we have such an all-star panel. Would hate to waste this opportunity. So, Rashmi, you had a question to start about trials. Do you want to pass that on now?
I was just saying that, as we discussed, it'd be nice to also talk about getting this to kids and what are the ways for both the IL18 binding protein and the Interferon Gamma blocker. So, this is less a question, more
why don't you?
We should do some clinical trials.
Yeah, so I mean, I think all of us, all four of us, are very interested in moving forward with compounds that block these targets. I think that we all have biomarkers that we feel like help define populations that are at risk. There's probably a fair amount of overlap, and I think mechanistically what we've tried to present has been that there's actually quite a lot of convergence here. I don't think we're actually disagreeing with each other in terms of what the effector cytokines are and what some of the risk factors are. But boots on the ground, I can say that it's a broken record, right? Heterogeneity. How do you design a study that is going to meet the criteria for robust evidence of safety and efficacy in a disease that is heterogeneous both between patients and within the same patient? It requires a long-term study. It requires novel outcome measures that are not validated, and probably dozens of other things I can't even think of. So I mean, getting pharmaceutical companies on board with that. I mean, every step of that is an iterative risk, I think.
Fabrizio, on the
so we did design the study, and it's ready to go. It is actually going to RMBs in the next days, I would say. It's going to be a pilot study based on that dosing regimen that I just showed. The study is designed as a pilot study in a rare disease with all the caveats and issues to be solved or tried to solve, that we tried to solve, that you just outlined. It's a very difficult study. The other point I want to make is biomarker. So biomarker are going to be the key issue here to define the response and the heterogeneity of the population. And I think that the clinical trials are the best option we have to define the value of the biomarker vis-a-vis the novel treatment which is being developed.
But I mean, so, and I would love to hear Gina Montealegre is sort of intimately conducting a compassionate use trial that she'll talk about later in the study. But the company that sponsored that trial has had a very difficult time. When they do their business analysis of the investment, it would be interesting, and I'm sure that, Novamine's not going to share it, but what is the business model for investing what must be close to $1 million a patient for this kind of a pilot study? That's a rhetorical question. I'm not...
I can certainly speculate, and I'm going to talk about this later today. It's a very unusual model that requires a complete rethinking from a number of stakeholders. So far, we've managed to get this point, but I can tell you, every 6 months we are running the risk of not being able to pick the salary of our people. Because doing this kind of research, you may like it or not, it is very expensive. I just want to give you one piece of evidence, okay, so that I cannot give you any other number, that every time we flew one sample of one patient across whatever, the Atlantic rather than Europe
the Alps,
or the US, regardless of whether it's Saturday, Sunday, night, and because to learn how to study, how to investigate certain things, you need to do a lot of monitoring. Otherwise, you cannot get this kind of data, right? It costs on average $2,000. And the sample may be refused by the pilot, which triggers a number of other issues. So it's just that I don't want to give you any other decisions, but give you a hint of what are the obvious difficulties that we're facing every day.
So I think we'll have some time to discuss this a little bit further also, but let me just address, see if there's any additional, dive in. Yeah.
So, you know, and we're also opening up a trial for IL18 binding protein, you know, for NLRC4 and for ZIAP and other indications, and it's all, I mean, it's the same story, and it's the exact same story, and we've had samples stuck in customs, and it's a nightmare, and, you know, it's just, this, I think, in some sense, Rashmi, this is sort of maybe the main goal of this thing is actually less about the science and more about the logistics of how do you advocate for rare disease research, how do you advocate for trials in rare disease, and I do think it requires out-of-the-box thinking for pharma. I think it's going to require out-of-the-box thinking for regulators. I've been a little sort of surprised in many ways at you know, some of the requests to sort of run it like a hypertension or an erectile dysfunction trial, you know, which when you don't have 500 patients, you know, it's just not going to happen. So I think that you know, this community sort of giving a voice to the challenges of rare orphan disease and almost sort of ultra rare orphan disease is maybe where the advocacy can happen.
I see one more problem here. So we are dealing with MAS, for example. We have episodes of inflammation. They may occur at certain frequency, and when we use the drug, how is it for dealing with just acute episodes, or kind of it's a baseline therapy to keep things under control? With IL18 binding protein, I think we have a very different experience. I was very impressed with the fact that when you started treating your patients, you knew that the patient was responding 48 hours later. Rashmi, what do you think about our experience? I think it took us probably 2 months.
Yeah, to understand.
To understand.
The context was different. When you give something in an acute, you know, case, then you can understand better. I think in our case, we gave it when he was very high on steroids. So it has taken us, as we've been down the steroids, to really understand the impact of any other medication. So I think
but it still brings up the problem is sort of what the design is going to be, and who is going to be eligible for the trial based on that.
So let me throw it up to a change in topic. Other questions, other discussion ideas? Please.
I think parents should get first shot. It's a bit like Wash U.
Sorry, please. Yeah, good idea.
Because we will jump all over each other.
More of a science question. I mean, you presented lots of good data. It looks like IL18 and Interferon Gamma seem like to be at least the good biomarkers for inflammation. You didn't present how they were related to each other, though. Is there any relation one or the other that if you got a patient who treated Interferon?
So I think it's because it's such a fundamental sort of idea in immunology. So IL-18 was first identified and was called interferon gamma inducing factor. So IL-18, one of its main jobs, at least canonically, is to promote interferon gamma production. And this has been shown in lots of different systems in lots of different ways. And I think what we're trying to point at is that the patients that we call MAS seem to sort of exist in this sort of extremely high amount of IL-18. But clearly, IL-18 is not sufficient to drive MAS because many of your children are walking around with unbelievably high levels of IL-18 when they are going to dance practice. And so, you know, it's IL-18 plus or it's perforin deficiency plus something else that leads to this, you know, a response that should be this big becomes an interferon gamma response that's this big. So
right, and we can prove this. We did prove this in our patient. These are the slides I missed. We had our patient we had a serum sample from our patient, NLRC4 patient, when he was very sick, and his level of IL-18 were above 300,000 of picoramel. We stopped diluting it out. Yeah. We thought it was enough. So we put the sera of the patient on healthy mononuclear cells, on healthy immune cells from our healthy controls, and we tested whether that sera was able to induce interferon gamma, and it did so only in the presence of IL-12, and Pierre is going to know why. It did so only in the presence of IL-12, so the sera plus IL-12 did induce interferon gamma, huge amount of interferon gamma, and if we added the antibody to IL-18, that was neutralized. So it's clearly IL-18 is not sufficient, but it's very helpful in inducing lots of interferon gamma. By itself, it's not sufficient. So there must be something else, and we have to figure this out.
Do you want to amplify on the immunological biology there?
I can explain if you want, but there is an interaction between IL18 and IL12. It goes that way. The first is IL12, and for a cell to respond to IL18, it's sort of obvious there is a need to have the IL18 receptor. So IL12 will induce a modest amount of gamma interferon, but at the same time will make the cell able to respond to IL18. So then IL18, which was not able to activate the cell, can do so now, and you have a massive synergistic.
That's only in T cells.
That's only, I was going to ask the same
and
thing.
only in naive T cells.
Leading at the end to the massive induction of gamma.
But that's only T cells.
Only naive T cells. Memory CD8s respond beautifully to IL-18 without 12
it's the same for IL-33, because we've done those experiments for IL-33, where we can show the same thing. You take a naive T cell, it expresses no ST2, you chuck in IL-12, all of a sudden it expresses ST2.
Is that human?
These were mouse experiments. But then memory T cells express it.
So, Christina, do you have a...
Yeah, MAS is very interesting. And what about MAS in another context, like in sepsis patients? Would you see the same signature in sepsis patients? Because, there were two failed trials for angina and sepsis in the mid-90s. And now the PIs for those studies are reanalyzing the data and looking at mouse-like features, like ferritin levels, and see that in the subset of patients with mouse-like features, they responded to angina. So would you also, if you look for like IL-18 or Interferon Gamma signatures, do you think you will see the same?
So you looked in sepsis.
What's that?
You did look in sepsis patient. I think you.
Oh, infection-associated HLH. I mean, sepsis is even more of a basket diagnosis than MAS. But I personally believe, and I don't have any data to support this, but probably, when we talk about sepsis, there's different flavors of inflammation within that. There's not just one kind of inflammation. And probably if you, had the drug available, and I'm sure Novimmune is thinking and salivating about this, and it's probably part of the business plan, that you prove that interferon gamma is successful in a clearly interferon gamma de-risked disease like primary HLH, and then you look for that signature that is defined by a genetically defined disease in something that affects, that kills 300,000 people a year in the U.S.
But we need data. We need the data.
Absolutely, we need data. But something to look for.
Yeah.
So we'll have more time for discussion at lunch and at different times here. So I think we should wrap it up there. We're already 20 minutes over. Is that, yes? Good.
So
Okay.
we are break now, and we had a 20-minute break.